For this presentation, we will be covering bronchopulmonary dysplasia and respiratory distress syndrome. This is the outline for our presentation, which includes objectives, introduction of bronchopulmonary dysplasia, signs and symptoms, pathophysiology, case study, anesthesia management, summary, and references. Here is a list of our objectives for this presentation. By the end of this presentation, you should be able to define bronchopulmonary dysplasia, describe the pathophysiology of this disease, identify the risk factors, review the signs and symptoms associated with this disease, and also describe the anesthesia implications and management of a patient with bronchopulmonary dysplasia. Bronchopulmonary dysplasia, or BPD, also known as chronic lung disease of prematurity, is the major cause of pulmonary disease in infants. It is associated with premature birth, gestational age less than 28 weeks, perinatal supplemental oxygen, and positive pressure ventilation. It is a chronic disease of the lung parenchyma and small airways with chronic respiratory insufficiency that occurs in prematurely born infants. The incidence of respiratory distress syndrome, or RDS, and bronchopulmonary dysplasia is inversely related to the gestational age at birth. The onset of RDS can be as early as 6 hours after the premature baby was born. Oxygen toxicity, barotrauma, caused by positive pressure ventilation of the immature lungs, and endotracheal intubation have been reported as causative factors of bronchopulmonary dysplasia. Currently, BPD is graded as mild, moderate, severe based on the oxygen requirement and the need for ventilatory support. The current definition of BPD is oxygen dependence for at least 28 postnatal days. Bronchopulmonary dysplasia is a multi-system condition associated with developmental disorders in other systems such as pulmonary hypertension, neurodevelopmental delays, hearing defects, and growth retardation. Infants affected by this disease can develop lifelong alterations in their lung function, compromising their overall quality of life. Now we're going to review the signs and symptoms. Patients with BPD will need oxygen supplementation. They might develop lower airway obstruction, air trapping, CO2 retention, atelectasis, bronchiolitis, and bronchopneumonia. They might show low or decreased oxygen saturation, retractions, grunting, and tachypnea. Pathophysiology. Lung immaturity and inflammation contributes to the development of BPD. In preterm infants born before 28 weeks of gestation, the fetal lung is in the canacular stage of development, which usually occurs at 16 to 28 weeks, a critical period during which type 2 epithelial cells appear, capillaries grow into the future distal alveoli regions, and the interstitium begins to condense. The extensive network of alveoli developed by septation between the terminal respiratory unit, beginning in the saccular stage, starting at approximately 26 to 28 weeks. The alveoli are vulnerable to inflammation and impair growth during this stage. In the current era of neonatology, the widespread use of antenatal glucocorticoids, postnatal surfactant, and nasal continuous positive airway ventilation has decreased the incidence and severity of RDS, and in consequence, also decreasing the incidence of BPD in premature babies. Before the widespread use of surfactant therapy, classic BPD was a disease characterized by airway injury, inflammation, and parenchymal fibrosis. Now, after the initiation of surfactant therapy, what is called new BPD is most often a form of arrested lung development with poor formation of the alveolar architecture. Alveoli are large and fewer in numbers, thereby presenting decreased surface area for gas exchange. Mild pulmonary fibrosis, accompanied with persistent inflammation, contribute to the perfusion mismatch and pulmonary hypertension. Here are factors that contribute to the development of BPD. Volutrauma, due to decreased compliance and excessive tidal volume. Oxygen-free radicals, which can cause direct cellular injury. Even room air is relatively hyperoxic for a premature infant. Excessive hydration and patent ductus arteriosus with increased pulmonary fluid. Infection and inflammation. As recurrent bacterial or viral infections in premature babies might cause persistent alveolitis, which worsens alveolar and airway damage.
So in this case study, we have a female infant weighing 950 grams who was born through normal vaginal delivery at 27 weeks. She was diagnosed as being premature. She was found to be in respiratory distress syndrome. She was septic. She had bronchopulmonary dysplasia, retinopathy of prematurity, transient hyperthoraxemia of prematurity, and intracranial hemorrhage. She's being brought to the OR for laser treatment for her ROP. On the assessment, she was found to be tachypnic with retractions. Her chest x-ray showed complete atelectasis of the right lung, and ultrasonography revealed both ventricles were dilated. She did an echocardiogram and was found to have atrial septal defect as well as some tricuspid regurgitation and a patent ductus arteriosus. So initial assessment also revealed a pulse ox of 94%. They were able to mask ventilate and increase her pulse ox to 97%. She was induced with a mixture of sevoflurane and oxygen, and they proceeded to insert an LMA, which subsequently dropped her sats to 70%. So they put in a second LMA with the same results. Finally, they tried to place a breathing tube in, and they chose a number 2.5 and failed initially due to the edema in the pharynx and larynx, and as well as secretions. So they bag masked her again and were able to bring her sats up, and they proceeded to place a larger ET tube, number 3, and were successful and were able to bring her sats up to 100%. They then proceeded with the surgery. It was 30 minutes long, successful it was successful for the retinopathy, and they were also able to successfully resolve the atelectasis, not in surgery, but in the NICU following surgery. So what can we take away from this case study? First, it is crucial to review and understand the neonate's history and comorbidities, as these can be useful tools with which to optimize care and anesthetic management. BPD in and of itself does not always warrant endotracheal intubation, and oftentimes it is avoided due to the presence of, or the risk rather, of increased reactive airway. However, in this case, with the added comorbidities of neurological involvement, cardiac involvement, a more thorough and aggressive anesthetic plan should have been established. Complete atelectasis of the right lung should have triggered the idea of ventilatory support with its volume control and pressure control and expiratory pressure control. The failed attempt of an LMA should not have been followed by a preceding second attempt. Trauma of the airway is very likely to increase with every subsequent attempt. It was also surprising that they intubated twice. However, the patient was able to be ventilated finally and brought up to 100% SpO2. It was not discussed who was in the room or who was making the decisions, but I think that it is always important to remember to call for help and to get as many people involved in the decision-making process, as this can oftentimes lead to better and more effective care. Now, in regards to anesthesia management and specifically ventilatory management, it's important to discuss the settings with which to provide optimal pulmonary support. The pulmonary function in infants with severe BPD is dominated by increased resistance and expiratory time that is very long. In infants with the most severe form of BPD, time constants for exhalation may be as long as 0.5 to 0.75 seconds. Complete exhalation, by definition, requires 5 time constants and thus may require as long as 4 or 5 seconds. So if too high a respiratory rate is set on the ventilator, there will be inadequate time for exhalation, and the subsequent breath will begin with the lung already partially inflated, which we know as breath stacking. This cycle will occur with every breath. The damaged portion of the lung will rapidly become hyperinflated and will not be able to contribute meaningfully to overall minute ventilation. The primary goal of ventilation in infants with severe PPD is to allow adequate time for complete emptying. If we take the example, assuming an inspiratory time of 0.5 seconds and an expiratory time constant of 0.6 seconds, the minimum inhalation-exhalation cycle length consistent with full exhalation would be 3.5 seconds. That's inhalation of 0.5 seconds and exhalation of 3 seconds. And the maximum rate that could be used for the ventilator would be the 60 seconds divided by 3.5 seconds per cycle, or 17 breaths per minute. Any respiratory rate greater than 17 in this case will result in breath stacking, which again would result in hyperinflation and insufficient ventilation in the bulk of the lung. This would lead to VQ mismatch and hypoxemia, which would manifest as an increased oxygen requirement and potential further collapse of the lung. Bronchopulmonary dysplasia should be suspected in all neonates with a history of prematurity, as it is the #1 cause of the disease. Ventilator-induced lung injury is also an important risk factor in the development and treatment of BPD via volutrauma, barotrauma, and atelectotrauma. Traditionally, LMAs are the preferred methods for airway management in patients with BPD due to the reduction of reactive airways, but should not be used blindly. Anesthesia management should include general anesthesia with the placement of endotracheal tubes, especially in the presence of other comorbidities. This facilitates more accurate and effective ventilation. Appropriate ventilation settings include slow respiratory rates of 15 to 20 breaths per minute, high volumes of 10 milliliters per kilogram, and positive and expiratory pressure in order to keep the lungs proficiently ventilating.
These are our references.